Hi, Professor Wines and class. My name is Annie, and I'll be presenting my grand rounds on ovarian cancer. This topic is especially important because it's still a leading cause of death in women worldwide. I will review the pathophysiology, epidemiology, and risk factors for ovarian cancer. Then I will discuss typical clinical findings, differential diagnoses, diagnostic tests, prevention, treatment options, patient and family education, best practices, and follow-up care. So let's get started. We used to believe that ovarian cancer originated in the ovary, but we have learned that the fallopian tubes are the most common site of origin. The reason we thought it originated in the ovary is largely based on appearance at the time we detected it. The ovary is in close proximity to the fallopian tubes and is often what is palpated, initiating the diagnosis of ovarian cancer. The fallopian tubes as site of origin would explain why ovarian cancer screening is largely ineffective in the early stages. There are a lot of unknowns with ovarian cancer. For example, we do not know how long ovarian cancer takes to develop because we do not detect it early. We do know that the pathophysiology varies based on the cell type and site origin, but we do not know the details. We also know that ovarian cancer does not show a clear progression, and all of these factors make diagnosis and treatment more difficult. Ovarian cancer originates in one of three cell types, either the epithelial, stromal, or germ cells. Up to 90% of ovarian cancer originates from epithelial cells, and malignant epithelial ovarian cancer split up into 5 histotypes: high-grade, endometrioid, clear cell, mucinous, and low-grade serous. Ovarian cancer is the 7th most commonly diagnosed cancer in women. 75% of ovarian cancer is diagnosed in the late stages, meaning either 3C or 4. And in the late stages, ovarian cancer is harder to treat and has a higher death rate. The highest rates of ovarian cancer are in developed countries at 8 per 100,000 women. The lowest rates are in South America, Asia, and Africa at 5.8 to less than 3 per 100,000 women. Of interest to me was that when someone migrates from a lower risk area to a higher risk area, there is an increased risk that shows the importance of some of these environmental factors. So this means that even in a lower risk area such as South America, Asia, or Africa, the risks for ovarian cancer were higher in the urban areas compared to their rural areas. 1 in 75 women will develop ovarian cancer in the United States. 15% of these women are diagnosed in stage 1, where the 5-year survival rate is great, it's 92%. However, 85% of women are diagnosed in the late stages, where the 5-year survival rate is only 29%. Since 1995, the survival rate has only increased by 2 to 4% for those with ovarian cancer, which shows that advances in ovarian cancer are minimal. The factors that increase a woman's risk for ovarian cancer are earlier age of menarche or older age at menopause, hormonal replacement therapy, PCOS, endometriosis, and pelvic inflammatory disease, urban areas, as discussed earlier, obesity, IUDs, and then it's hypothesized that asbestos, talc powder, and cigarette smoking also increase the risk, but there's less strong evidence for those. The factors that decrease a woman's risk for ovarian cancer are parity, lactation, exercise, tubal ligation, bilateral oophorectomy. So that's kind of interesting. You'll see that if we remove both ovaries, it decreases the risk by 90% but does not completely get rid of it, which either supports a very slow-growing disease, so there were cells elsewhere, or origin of cancer elsewhere. There's also a 20% decreased risk for every 5 years of oral contraceptive use, and the benefit persists decades after oral contraceptive use has ceased. So when we're prescribing birth control pills, we'll realize there's an increase in breast cancer, but there's a decrease in ovarian cancer risk. So we'll always want to weigh all of those pros and cons with our patients. Some cancers are caused by mutations in your germline DNA that you inherited from your parents, which explains families with a prevalence of various cancers. However, most cancers, including ovarian cancer, is caused over time by environmental factors that cause mutations in your somatic DNA and is not inheritable. Ovarian cancer is known to be associated with at least 2 known inheritable genetic cancer syndromes, including HBOC, which is hereditary breast and ovarian cancer syndrome, and Lynch syndrome. Each of these genes are involved with repairing broken DNA and preventing mutations from being passed on to subsequent cells. When these genes are mutated themselves, they are unable to keep DNA in good order. Over time, as the cells reproduce, mutations accumulate and eventually turn into cancer. Angelina Jolie is well known for her decision to have a prophylactic mastectomy in 2013 at the young age of 35 due to a mutation in her BRCA1 gene. In 2017, at age 39, which is also quite young, she had a prophylactic oophorectomy and salpingectomy. Her family history is typical of one with hereditary breast and ovarian cancer. Her mom, grandmother, and great-grandmother all died from ovarian cancer. Her cousin, aunt, and great-aunt died from breast cancer. Her grandfather and uncle died from other cancers that are also associated with hereditary breast and ovarian cancer syndrome. You can see on the slide that mutations in the BRCA1 gene confer a 35 to 40% risk of ovarian cancer compared to the 1 to 1.4% in the general population. Angelina Jolie has advocated for genetic testing and brought a lot of awareness to the syndrome. This Angelina Jolie effect resulted in a lot of women who were both high and low risk for inheritable cancer syndromes requesting genetic testing. Of note, I worked as a genetic testing specialist reviewer for about 4 years at an insurance company, and I saw a lot of requests due to her publication of the issues. I hope that more women with these mutations will follow her example and have their ovaries removed. As you will soon see on a later slide, many of these women with these high-risk mutations do not undergo prophylactic surgery due to side effects and concerns about side effects. Ovarian cancer syndromes aren't very apparent in the early stages of the disease. As you can see above, many of the symptoms mimic common stomach and digestive complaints that we see in primary care. And I'm realizing that my picture is obscuring this, so let's move me over here. So OC stands for ovarian cancer, if I did not define that earlier. So many of these complaints, fatigue, appetite changes, pressure in the pelvis, urinary frequency or urgency, changes in bowel movements, increased abdominal girth, changes in menstruation, abdominal bloating, indigestion, and nausea. These are very common complaints that we see in primary care. Women are more likely to experience symptoms that are more clearly malignant once the ovarian cancer disease has spread beyond the ovaries. The message here is that ovarian cancer should always be on our differential for women with the above complaints, because we are integral to referring them to appropriate screenings and care with gynecological oncologists. Okay, on to differential diagnoses. When there is no mass palpated, the differential diagnosis for ovarian cancer is too large to discuss here, since the symptoms are so nonspecific. However, you'll notice in one of my questions at the end of this presentation that I ask for you guys to discuss some non-gynecological differentials for ovarian cancer. So if there is an I can never say this word, ADNEXAL mass, the differential is still large and includes several benign differentials. These include several types of cysts like functional, polycystic, paratubal, and paraovarian cysts, benign ovarian germ cell tumors, and ectopic pregnancies or other options. Of note, ADNEXAL mass is more likely to be benign compared to malignant, so all the differentials above should be explored. To differentiate between benign ADNEXAL masses and ovarian cancer, transvaginal ultrasound is needed. The masses that are cysts or abscesses will show fluid and no solid material on the transvaginal ultrasound. Now let's go to the next slide to see details on typical findings on the transvaginal ultrasound that are suggestive of ovarian cancer. The overall size of the mass is no longer associated with risk for malignancy. However, the following characteristics are high risk for ovarian cancer. Features of malignancy such as solid or nodular mass. So remember, the cysts are going to have fluid in them, but if it's malignant, it's more likely to be solid. Or they'll have thick septations that are greater than 2 to 4 millimeters. Ascites, peritoneal masses, enlarged lymph nodes, or matted bowel also suggest malignancy. In 80% of women with ovarian cancer, the CA-125 tumor marker, or the cancer antigen 125 tumor marker, will be elevated. Of note, the CA-125 tumor marker is also elevated in 1% of healthy women and women with endometriosis, uterine fibroids, liver disease, pelvic infections, and other cancers, including cancers of the endometrium, breast, lung, and pancreas. So there's limited benefit to that screening. Now, if any of these high-risk features are found, the patient should be referred to a gynecological oncologist. Little is known about primary prevention for ovarian cancer in the general population. Diet and exercise has been linked to all types of cancers, so it's reasonable to advocate for these measures in our patients despite no specific research that links ovarian cancer to these measures. I did find an article by Guo et al. In 2018 that linked low vitamin D levels to ovarian cancer. I was not convinced that the level of research in this intervention was high enough to recommend to our patients, since it was not listed in any of the clinical practice guidelines that I reviewed. However, it might be a good thing to keep an eye on this research in the future in case it becomes stronger. Prophylactic oophorectomy is a type of primary prevention that's no longer recommended for patients without a known cancer syndrome. In the past, this was done, and then it was discovered that there was an increased mortality from cardiac and neurological causes after removal of the ovaries. In fact, the all-cause mortality from these issues is higher than the risk reduction from removing the ovaries. So that means if you were to not have your ovaries removed, the percentage of risk of your death from ovarian cancer is going to be less than the percentage of risk factors from all of the other mortality causes that happen after you remove the ovaries. For those with hereditary breast and ovarian cancer syndrome or Lynch syndrome, prophylactic removal of the ovaries is an option that is effective and results in a lower overall mortality risk. So you remember that in the earlier slide, we showed that women with hereditary breast and ovarian cancer syndrome can have up to a 40% chance of getting ovarian cancer. So that's going to be higher than the other mortality risks from an early or premature removal of the ovaries. Unfortunately, medical professionals often have a hard time convincing these highest risk women to undergo surgery. And this is what I was referring to when I was glad for Angelina Jolie's outspokenness or education on this matter. Now, as our knowledge of the origin of ovarian cancer has grown to include that it develops in the fallopian tubes, discussion about just removing the fallopian tubes is emerging as a primary prevention measure. With my current knowledge of ovarian cancer, I would suggest instead of having the tubes tied, surgical removal of the tubes should be considered as a contraceptive and preventative measure in our patients who are desiring permanent contraception. An article by Singer et al. In 2015 states that the serum test, the cancer antigen 125, and transvaginal ultrasound is now shown to be effective as a screening tool, whereas this was not the case previously. An article by El-Bari et al. In 2017 cites that there are many promising biochemical markers that have yet to be validated. The pelvic exam is the only secondary and or tertiary prevention measure I saw listed in other clinical practice guidelines. So this was an area where the consensus was not unanimous. Okay, cancer treatment is quite complicated. It's highly individualized and depends on risks from the patient's germline and somatic DNA mutations, various therapeutic and prognostic biomarkers, the stage of disease, etc., subtype of cancer, meaning whether it's epithelial, neuroendocrine, or one of the other histological subtypes. So the big debate that's a little more applicable or understandable to the nurse practitioner is whether surgery or chemotherapy should be done first. The benefit to doing chemotherapy first is that the cancer size is reduced and surgery time is less intense. However, if chemo is done first, the patient is often sicker and less resilient to the harms of surgery. Of note, Europe and the United States have kind of flip-flopped on this. So there's a lot of research to be done as to which approach is best. Now, there are also many, many types of chemotherapy being researched. The first-line chemotherapy for the epithelial type of ovarian cancer is a platinum and taxane agent combined. I'm not sure how to say these. Olaparib and bevacizumab are chemotherapy agents that can help with the progression-free survival, but haven't been shown to affect the overall survival. I'm not going to discuss any more of the chemotherapy options since as future nurse practitioners will not be involved in the chemotherapy decision making. We will, however, need to be able to read up on the most up-to-date research on the agents given to our patients so that we can make sure vaccinations are given at appropriate times, that there are no medication interactions between the chemotherapy and the patient's baseline drugs, and to look for complications from chemo that require immediate intervention. I have listed various non-pharmacological measures above as well. Excuse me. Ovarian cancer treatment will necessitate a multidisciplinary team made up of primary care, OBGYNs, surgeons, radiologists, oncologists, home health care, care managers, chaplains, etc. Family nurse practitioners will be able to contribute primarily to comfort measures during ovarian cancer treatment. Family nurse practitioners are more likely to be involved in patient care after remission is obtained in the means of hormone replacement therapy. As I mentioned earlier, oophorectomy increases morbidity and mortality from several causes. These include heart disease, Parkinson's disease, other cognitive declines, and decreased sexual function. Hormone replacement therapy, commonly known as HRT, does confer increased risk for breast cancer, but it does decrease some of these other risks, some of the risks with heart disease and cognitive function, and even sexual function. So overall risk for breast cancer and these other causes should always be assessed prior to initiating hormone replacement therapy. All right, so for education, let's move me over. Patient family education should include the following domains: ovarian cancer prevention, treatment, impact on fertility, and end-of-life care. Since ovarian cancer is rare and usually diagnosed late, and since prevention and treatment have already been reviewed, I'm going to focus this patient and family education on end-of-life care for women with ovarian cancer. And I'll briefly touch on the fertility piece. So obviously, if you've had ovarian cancer, you will have had your ovaries removed, and that will remove the option for fertility. There are some options to harvest eggs before, but usually the risk is too high, so that's not usually done. Hospice is a great option for our patients with terminal ovarian cancer. Hospice can reaffirm the teaching that we provide as options to ensure comfort during the dying process. We want to make sure our patients know that we will be there, that we can make sure they don't have pain, that we can keep them comfort, that we can keep their family involved. All of those things are extremely important. Best practices and optimal outcomes for those at high risk for ovarian cancer and those with ovarian cancer. The current guidelines, prevention guidelines, suggest that genetic testing for all those at high risk for ovarian cancer should be done. If a positive cancer syndrome is detected, then transvaginal ultrasound and CA125 biomarkers should be assessed. The interval was not discussed. Also, we would want, if a positive mutation is detected, then that single site mutation should be tested in family members to assist their risk and to assist them in prevention measures if needed. The guidelines from various organizations do not agree, and the research is ever changing. So referral to a gynecologist who specializes in oncology should be done for those at high risk for ovarian cancer and for those that have ovarian cancer. The best outcome for these patients comes with a multidisciplinary approach. These are the questions that I will repost in the discussion. Want to know about what are some of the common symptoms of ovarian cancer, and then what are some non-gynecological differentials for ovarian cancer, and what other education would you provide? Let me move my screen here. Would you provide to the patient or family with ovarian cancer? And some of this could be pulled from the prevention slides that I did not reiterate on the patient and family education parts. And then I have got several slides of references. All right, well, I thank you for your time, and I look forward to your discussion about other differentials for ovarian cancer and patient education for ovarian cancer. Thank you.